Good afternoon, everybody. Welcome to today's closing plenary session. My name is Weinstock. I'm the director of the Institute for Health and Social Policy at McGill University, which is sponsoring this event. You will find in your packages a very attractive two-page, I guess it's not really a flyer, that explains what the Institute is about. So please connect to our website. If you're based in Montreal, of course, you're always welcome to our events. You're even welcome to them if you're not from Montreal, but I would imagine a little bit more of a challenge getting to them in that case. We are an institute very much in line, I would say, with the theme and spirit of the conference here. We're interested in the ways in which social policy and social conditions impact the health and well-being of individuals and communities, both nationally and internationally. And of course, anybody who's looked at the literature on the social determinants of health knows that issues to do with income and income disparity loom large in that literature. So I'm very glad that through the Institute and also through my professorship here at the Faculty of Law, we've been able to help make this conference possible. It's a great honor to welcome all of you here and to be associated with the international event that will be starting here, I guess, tomorrow. So it's my very great honor to introduce our plenary speaker this afternoon, Dr. Reid. Dr. Reid has a very impressive vita, which he has told me that I should cut down to the bare bones. I will tell you that Dr. Reid was born in Nairobi, which is kind of an interesting fact. Received an honors degree in wildlife biology from the University of Guelph in 1981, and her medical degree from the University of Ottawa in 1986. In 1988, she completed her family practice residency through the University of British Columbia and spent the second year in remote Bella Coola, BC. In 2000, she returned to Vancouver to complete further critical care and trauma training. I'm going to take to heart Anna's invitation to cut the CV down to the bare bones and fast forward all the way down to the point of telling you that after a decade and a half of very impressive accomplishments, including a large HIV practice, AIDS network, Kootenai Outreach and Support Society in, I guess, the late 1990s. She is the just outgoing president of the Canadian Medical Association, 2013-2014. So are you now past or are you soon to be past? Soon to be passed. So, still not quite past president of the Canadian Medical Association. So, without further ado, I invite Dr. Reid to take the stage.
So, I actually am past president for another 7 weeks, and then I will be past being past president. That's Anyway, thank you. Let me know if this thing's ringing too much. Does that sound okay? Am I too close? Or that's okay. So thank you so much for the invitation to be here today. It's a great honor for me and just a huge privilege to be amongst people who care so deeply about those who are less fortunate than I am. And I feel truly privileged in my life. I was lucky enough to grow up in a middle-class family near Hamilton. And my father was a high school teacher, and my parents took education seriously and saved their pennies and put me through university, and then I was able to work my way through medical school. And so even though I did not come from a highly affluent family, I came from a family that provided the basics that we really know that are necessary to really achieve in life, and actually, by achievement I mean actually live a life that's healthy in the way the World Health Organization would define health. So one of the things that that sort of background that I have has left me with is a huge sense of social responsibility. My parents gave that to me also. They were huge environmental activists, and I've taken my path into medical and social activism. So I don't think I would understand issues about income and poverty issues unless I actually had not worked in the front lines in the real trenches of healthcare for the last 30 years, and I don't think I'd really understand unless I'd actually walked alongside many of my patients that I've got to know quite well. So I'm a family physician initially, a rural family family physician, and I now work exclusively as an emergency physician in Yellowknife in the Northwest Territories. And I did start my career working in isolated Aboriginal communities up the British Columbia coast, and I later made my way through rural BC en route to the north. So I have worked for a very brief period of time, about 4 months, on the west side of Vancouver in one of the most affluent neighborhoods of Canada. I hated my work there. I felt completely out of touch with the people there, and it was quite interesting to me that their health issues were so different from the other patients I'd served along the way. So I actually became president of the Canadian Medical Association actually a little bit by chance. The chance came for that presidency to come to the Northwest Territories, and we have such a small group of physicians up there that no one else really wanted to run. So here I am, and I would never have got here any other way, but I'm glad I made it. But I actually did decide to take the 3-year commitment on because of feeling that we have not, as physicians, actually advocated for that we really need to in our society. And, you know, having worked amongst northern poor Aboriginal communities for most of my career, I really understood that we actually have to start putting our voice to what we see as physicians. So many of what I'm going to talk about here might relate to my photos more to the north where I work, but I think the lessons from there are actually well shared with down urban inner city health, refugee, immigrant health around Canada. And they also apply to the well-kept secret of hidden poverty in this country. So I think many Canadians really underestimate how much poverty is among us and how many of the people in our communities really live very challenging and difficult lives. Now I got to figure out how to work the keyboard here, somewhere in here. Okay, I'm a Luddite, so I actually need a tech aid just to hit a scroll button. Here we go. All right, okay. So why does the Canadian Medical Association care about poverty? Now, physicians are seen, I know, as fat blacks around the country, and I think in some ways that's a title well-earned. The Canadian Medical Association is not a negotiating body for physicians. It's our national organization of more than 80,000 physicians that actually's main goal is to advocate for the health of Canadians. In 2011, the Canadian Medical Association, in partnership with the Canadian Nurses Association, developed a document entitled Principles to Guide Healthcare Transformation in Canada. And this is a document that now has over 130 signatories of other healthcare organizations, grassroots organizations interested in equitable healthcare. So the principles that we developed when we made this document on what we call HCT were based on the Institute of Health Improvement's triple aim framework of better health, better care, and better value. The better health refers to population health, and that's what I'm mostly going to talk about in this talk. And when we developed some of the principles under the Healthcare Transformation Initiative, two things that came up loud and clear were health promotion and illness prevention. And the other one was that we need both health outcomes as well as a healthcare system that is equitable around the country. So what actually makes us sick? Now, I'm a physician that was trained in the Western medical model, and actually when I went through medical school, no one ever talked about anything about except just about physiology and anatomy, and not much about people. And what I've learned about people and society, I've sort of learned the hard way along the road. So when we first see our patients, like I might do in the emergency department, we generally get down to diagnosing and treating what's going on with them and trying to make a treatment plan, but we really don't often go beyond what really is going on that made that person sick in the first place. So, if you look at this graph, you'll see that only 25% of healthcare outcomes are actually determined by the healthcare system itself and the care you receive from physicians, nurses, etc. Another 15% of your individual health outcomes is actually determined by your individual biology, whether your father had heart disease, do you have a gene for breast cancer, that sort of thing. Another 10% is determined by your environment. Climate change will become more important here as we go on, air quality, that sort of thing. But you'll see that a full 50% of why we get sick is actually determined by what we call the social determinants of health, and really those circumstances that undermine or enhance your life. And so these are things from income, we're here to discuss today, early childhood development, your Aboriginal status, your race, are you an immigrant, your housing, your sense of community belonging, etc. And so the recognition of social determinants of health is not a new thing in the country, but I think it's only recently that there's a growing appreciation amongst people who actually governments will listen to, such as powerful physicians organizations, that there really is a large impact of these things on health outcomes, both individually and population-wise. So who cares really about the social determinants of health apart from the poor people out there who are affected by it? Like, why do I care? Well, actually, governments should care, because in Canada, per capita spending on health in 2010 was $4,445 compared to the OECD average of about $3,300. And what do we actually get for this? Well, out of 7 countries, Australia, Germany, the Netherlands, New Zealand, the UK, the US, and Canada, Canada actually came 6th out of 7th, and you can probably guess that the US was behind us. And we shouldn't feel smug about that, because we've done abysmally too. The Public Health Agency of Canada back in 2009 actually estimated that we spent about $220 billion per year on healthcare in Canada. And we know that over $40 billion of those dollars is directly attributable to socioeconomic factors. In other words, we are throwing away $1 in $5 into healthcare that we could be investing upstream in social determinants of health. We also know from UNICEF ranking of well-being of children, Canada came out of 17 out of 29 developed countries. And we also know that child poverty in this country is absolutely abysmal. So in the winter and spring of 2013, the Canadian Medical Association partnered with Maclean's magazine and CPAC, which is the Canadian Parliamentary Affairs Channel, and we hosted a series of 6 town halls around Canada, which I hosted, and we had a series of panelists. And the purpose of these were to gather Canadians' input on social determinants of health and how they affected them in their communities. So we had panelists that were medical, non-medical, community activists, educators, academics, journalists, and policymakers. And we had huge turnouts at these public town halls, and they were written up in Maclean's magazine, each of them. And we had people such as chairs of school boards, chiefs of police, community activists, business people, and as well as people living in poverty actually participate in them. And the questions that we asked were, the discussion was based around these 4 questions I have up on the screen. I won't repeat them now. But a number of themes emerged from the town halls, and they were actually summarized in a report we put out in July 2013 entitled What Makes Us Sick? And we had 12 recommendations that we forwarded on to the federal government actually from that report. So we're here to talk about income at this conference. I'm sorry I wasn't able to be here today and can't tomorrow, because I'd love to sit in on the whole thing. But we do know that more than 1 in 10 working-age Canadians live in poverty. And we also know that the single most important factor in health outcomes in Canada is poverty. Now, this may not seem surprising, because poverty affects so many other social determinants of health, such as housing and food and that sort of thing. However, I think what many people don't understand is that poverty is more than just an income level. So many communities are in poverty impoverished in other ways. They don't have infrastructure, they don't have services or opportunities. And we know that poverty in itself is a huge risk factor for illness. And being in poverty is it's a whole state of being beyond all those other things. Health-wise, the stress of being poor plays an immense role in our health. We know that stress leads to higher rates of diabetes, cardiovascular disease, cancer, all the autoimmune diseases such as rheumatoid arthritis and lupus. And most importantly, it leads to a much increased rate of mental health issues and substance abuse. And the stress is due, I think, largely to a loss of hope and an inability to see a way out of the situation and a feeling of lack of worth and dignity. And there's really a societal viewpoint that if you're not making money and you're not making good money, then you're really not worth anything. And that's really drilled into us. Childhood poverty is a national disgrace in Canada. 1 in 7 Canadian children live in poverty. This rate places us 15 out of 17 similar developed countries. Poverty in childhood can lead to multiple morbidities later in life. In fact, poverty in childhood is a greater predictor of cardiovascular disease and diabetes in adults than later life circumstances and behavior. We also know that poverty in childhood can influence early childhood neurological development. Child poverty rates are even higher for Aboriginal children, and this is disturbing on many fronts, not least the fact that Aboriginal populations are the fastest growing populations in Canada with the highest birth rates, and this is particularly true in Nunavut. And we also know that immigrant children have alarmingly high rates of poverty. So how does this relate to healthcare use? Well, again, poverty underpins most other social determinants of health, but is a factor on its own. And there is overwhelming evidence of the impact of wealth on health. The Canadian Medical Association did a public survey in 2012, and it asked Canadians about the link between their health and their income. When asked to rate their health, 70% of Canadians earning more than $60,000 a year said it was good or excellent. But only 40% of those earning less than $30,000 a year said it was good or excellent. That's a stunning 30% gap. And $60,000 a year is not even wealthy, as you look. The gap between the rich and the poor was well studied and work done by McMaster University in conjunction with the newspaper, the Hamilton Spectator. And they did a study called Code Red that some of you may have heard about. And this was a collaboration between the university researchers and the newspaper, looking at the difference in health outcomes based on where the people lived in the city and their income and educational status. And this study was of particular interest to me, having grown up just outside of Hamilton. And in Greater Hamilton area are located Burlington and Oakville, two of the most prosperous cities in Canada. And in Hamilton are also some of the poorest regions in Canada outside of the downtown east side in Vancouver. What Code Red found was it found staggering disparities in health outcomes between the rich and the poor. The life expectancy of those interviewed ranged from 86 years in the richest neighborhood to a mere 65 years in the poorest neighborhood. This was a gap of 21 years across just 2 kilometers. In other words, in Hamilton, we have pockets of third world life expectancies. But you know, this isn't just unique to Hamilton. This is something we know to be true in most of the rest of Canada, whether it be urban, rural, or remote. Code Red also found that the use of regular doctors by poor patients was actually way less, and in fact the access and use of primary care and preventive services was less than one would hope for. And as a default, and I know this working now exclusively in the emergency room, is people end up in the emergency room because they've not been able to access, for whatever reason, primary care. And that may not be because the primary care facilities aren't there. It may be because they're working poor with 3 jobs and they can't actually get to the family doctor during the restricted hours. There's many reasons for that lack of access. We also found in Code Red that mental health issues were dealt with almost exclusively in crisis mode and not in preventive team-based mode where there was proper treatment plans put in place. And in fact, it was dealt with through the emergency room. And certainly up north, that's a large part of my emergency room practice is mental health and addictions. So we know that Canada is one of the wealthiest countries in the world, but unfortunately, it's far from being the healthiest country. And we know that the gap between the rich and the poor in terms of income disparity is a major determinant of a country's health. Many developed countries, which are not as wealthy as Canada, nonetheless have better health outcomes. In the United States and in Canada, where income disparity is on the rise and is quite alarming, this situation is expected just to worsen unless we do something about it. And some of the good news stories are not always good news stories. Even in provinces such as Newfoundland, Labrador, which have actually traditionally been quite poor, the revenues now from offshore oil are making many previously poor people affluent. But those who are really marginalized are actually more marginalized now. They've been driven out of the housing that they were able to afford in downtown St. John's. And there's a whole new class of more marginalized people because of this new income disparity. None of this was intentional, but it's something we have to keep in mind moving forward as policymakers. Poverty was described by one of the Aboriginal chiefs in one of our town halls as being systemic violence. And I think we need to think about it that way if we really want to get it into our hearts that we need to do something about it. Although it's not discussed much in Canadian society, not nearly enough in my mind, early childhood development and education are probably the most important predictors of future health apart from income levels itself. This is most important before kindergarten, and really cradle to age 5 is where it's really important. And the first 18 months of a child's life is critical. And policy-wise, as we see more and more school boards going towards integrating kindergarten into the school system and pre-kindergarten into the school system, these are wonderful things, but what would be more wonderful is if we took pre-kindergarten age 4 money and we actually put it down to where we need it, which is in basic childcare in the early 18 months. So a Chicago economist a couple of decades ago, Dr. James Heckman, won the Nobel Prize in Economics for his work in the economic importance of investing in early childhood development and education. And he actually found that there was a return of investment of 8 to 1 in this particular area. And it's also felt that for disadvantaged children, the return on investment, investing in early childhood development and education is as high as 15 to 1. So why aren't we putting our money there when we know that? We know that early childhood development can actually be impaired by toxic stressors, such as a poor environment, poverty, and a lack of social support. Under extreme circumstances, these stressors can actually lead to the volume of a child's brain by age 3 being only 1/3 to 1/2 of the size it would normally be. Though that's a staggering thought. So in other words, the brain cannot wait for funding. We have to get on it early. In the USA, they started a program called Head Start, which was a comprehensive education, health, nutrition, and parental involvement program. And it was offered to low-income families and children. We're starting in Canada now to move this program out. It's out through Aboriginal communities, through Health Canada. And we do have some funded programs for Métis, Inuit, and First Nations kids. This is a program that should actually be across Canada, doesn't matter what race you are, where you live. So despite these laudable initiatives, we still know that only 17% of Canadians have access to regulated daycare. And we also know that Canada ranks last among 25 developed countries in meeting early childhood development objectives. So it's quite humbling to find that the US beat us on that.